Ladies and gentlemen, good afternoon. I'm Lieutenant Colonel John Severns, and I am the MC for today's town hall. As a quick reminder, everyone has the option of chatting right now, so if you have any questions at any time, please feel free to put your questions there. When we get to the Q&A session or section of today's town hall, if you would like to ask your question out loud, simply raise your hand using the raise hand option under reactions, and I will call on you to unmute yourself. With those remarks out of the way, General Bussier, over to you, sir.
Thanks, John. If you don't mind, can I get anybody just come up on frequency to make sure that we are transmitting, you can hear us?
Copy, sir. Loud and clear.
Loud and clear from you, Sam.
Thank you. So again, thanks for everyone taking the time to dial in. It was that time in the process of the study to give everyone an update. I'm guessing that some of you are joining this conversation for the first time, and many of you have been along for the last 20 months and in different forums. This is our 14th update to the community and to the command and to the Air Force on the efforts ongoing to address our cancer concerns in the missile career field. So we're about 20 months into this effort. And we will give you kind of an update since the last time we got together, but we're also going to try to give you an overview of the entire study. We are going to leave plenty of time at the end of this briefing for folks to ask questions, and I know there's folks out there that have questions, and we will give you time to do that. For the folks that are new or potentially haven't been tracking this effort, I just want to kind of give you an overview, a macro level overview of my intent of initiating this study back in 23. So it's multiple objectives. The initial objective within the scope of the study was to understand the as-is in our current missile fields. So the current conditions in our launch control centers and the Minuteman III missile wings, and all three missile wings, to have an understanding of the risk that we were potentially taking or exposing our airmen to. The next priority was to mitigate those risks and come up with institutional processes while we are operating this system until we transition to the Sentinel weapon system. To make sure our airmen understand those risks, they're properly documented in their medical records, and they're given the proper opportunity to take care or see their professional medical providers if desired. The initial focus was to make sure we understood the environment and to make sure we took care of our airmen and their families. That accounts for our current force. The study also is intending on understanding the scope of the exposure since 1976 to today and developing institutional processes that can account and record exposure and provide that information to the extent we can based on the fact we only have 3 Minuteman III missile fields remaining, and provide that documented evidence to the communities in the Department of Defense, to our separated and retired military members and their families, and probably most importantly to our VA partners in the Department of Veterans Affairs, so that we can document any potential exposure so our airmen, both current and ones that have separated or retired, have the ability and access to care if required. So that's kind of the macro level piece. We've learned a lot in this process, and Greg and Shiner are going to give everyone an update, and then again, we look forward to your questions. I have a few topics at the end that I'll bring up before we open up for questions too. So Greg, over to you.
Thank you, General Bussier. We can go to the next slide. Well, good afternoon. I'm Colonel Greg Coleman, Command Surgeon Air Global Strike. I want to thank you all for joining us this afternoon. As General Bussier mentioned, many of you may be joining the town hall for the very first time. So we want to spend a little time going over and providing you a recap of that timeline. And then from there, we will dive into the broader portions of today's discussion. So from the beginning, as this important dialogue began related to potential links of non-Hodgkin's lymphoma at Malmstrom, we remain committed to being transparent in our process and also prioritizing the safety of our missile leaders in the missile community. The process and the progress that we've made over the last 20 months remains in line with that commitment. So really in addressing that question there, do missileers and or the missile community have an increased cancer risk? Jerome Bussier directed this study to begin in February of 2023. And this study is really one of the largest that we've ever set forth to do. In discussions with the VA, this is the first study of its kind that combines both Air Force specialty code data with the base and location to operational activities, making it one of the largest and most comprehensive studies being done. And so this is an amazing effort, great partnerships with the VA, as well as the National Cancer Institute that helped and assist in designing the study as we have it. And so to get to that study design, we did conduct site visits and town halls to really understand the environment and to speak directly to the missile community so we could design the study appropriately. And that study is broken out into two parts. One is the epidemiology review, and that looks at comparing the 14 common cancers in the general population to the missile-related career fields. The review looks at the incidence of cancer rates, and requires an analysis of specific data sets to ensure that we're not only addressing the current population, those currently serving, but also looking at the locations where we had previous missile wings so we can address the concerns of those who have served. The second part is the environmental sampling effort, which is divided into 3 seasonal rounds. That assessment was done by our aerospace medicine professionals, the bioenvironmental engineers, and public health, and was informed again by the missileers in the community who work and live in those locations. The sampling effort includes industrial, occupational, environmental, and local chemicals and hazards, and looks at them across 3 seasonal rounds to understand any seasonal variation. And so those initial site visits led to some changes immediately. One was the halting of any burning material in our launch control centers, and the other was the update all the hazard signs and hazard locations throughout the missile alert facilities and launch control centers. Then moving forward in the summer of 23, the environmental sampling period began, and being consistent again with transparency and prioritizing the safety of our missileers and missile community. When the environmental sampling that was conducted came back, we had positive swipes for polychlorinated biphenyls that were above the EPA's recommended standard. And those were 4 out of 900 samples that were taken in 3 of our missile alert facilities. All of the 90 air samples were non-detect. We immediately shared this information at a town hall event, closed those 3 missile alert facilities, and shared that information with the community on our website as well as with the media. Those 3 missile alert facilities have been then cleaned and mitigated and are now back at full operation. In the fall of 23, USAF completed the second round of environmental sampling, finding all air, water, and soil samples to include radon to be below acceptable regulatory levels for any chemicals or hazards. That includes the efforts that were done at Vandenberg Space Force Base as well. And then that brought us to the epidemiology arm of the study, where USAF began working on the first phase of the epidemiology review, phase 1 alpha. Phase 1 alpha analyzed the DoD electronic medical records and included individuals with cancer using the military healthcare system. And that was a very small data set. The team found no increased incidence of non-Hodgkin lymphoma, but there was a potential trend for an increase in breast and prostate cancer. But again, it was the first and a very small data set, and so the study continued on to phase 1 Bravo. And then that brings us to where we are today. We will discuss the round 3 environmental sampling, but also look at the results from phase 1 Bravo of the epidemiology review that looks at the VA electronic medical records, the DoD cancer registry, as well as the VA's cancer registry. Go to the next slide. So this slide provides us a snapshot of the actions taken to date to include PCB cleaning at mitigation efforts, environmental sampling completed at Hill Air Force Base Strategic Missile Integration Complex. We're also conducting PCB swipes and air sampling in the launch facilities as well. And we expect to finalize those results for you in the 3 whistle wings very soon.
Sorry.
And then for the epidemiology review, we will discuss the phase 1 Bravo today, but as you can see on the slide, we're currently working on phase 1 Charlie, and then we'll begin analyzing data from phase 2, which is the virtual pool registry, to allow us to capture data that's not in the DoD or the VA system. So phase 1 Alpha and Bravo are within the federal system, and then we're able to see the state data through the virtual pool registry, because we know that many receive their care outside of the federal system. As we continue to do this work, we want to remain transparent with the public, whether that's on our public-facing website or engagements with the VA and their Military Environmental Exposure Subcouncil. And we continue to share information with them in order to expedite the process of getting benefits to our veterans. And that's also why we stay engaged with the veteran service organizations, so that we may keep them apprised of all the activities that we have going on. So those first couple of slides provide you with a great overview and a foundation for the rest of the brief, and then we can move on to the environmental sampling results. So we go to the next slide. I think Colonel Waldrop, you and your team will step us through the environmental sampling pieces of the study.
Okay, thank you, Colonel Coleman. This is Colonel Anthony Waldrop. I'm the Chief Aerospace Medicine for the 711th Human Performance Wing and the Senior Aerospace and Operational Medicine Consultant here at the U.S. Air Force School of Aerospace Medicine. I'll also add that I have subject matter experts from the study teams, both the sampling arm and the epidemiologic study. With regard to environmentally sampling results, the 3 seasonal environmental sampling rounds of all 45 operational missile alert facilities have been concluded with 8,400 samples collected and analyzed. Additionally, environmental sampling has been completed for Vandenberg Space Force Base and Hill Air Force Base Strategic Missile Integration Complex. I'm happy to report that all air, water, and soil samples were below acceptable regulatory levels for any chemical or hazards. Additionally, radon levels were below intervention thresholds for all 5 bases. As previously reported, of the 1,205 samples, the surface swipe samples that were collected at all 5 bases, there were 68 swipe samples that detected PCBs below the 40 CFR 761 limit of 10 micrograms per 100 square centimeters. There were 4 PCB surface swipe samples that exceeded the 40 CFR 761 threshold. A great effort has been taken to date to mitigate PCBs and prevent exposure. And I'll turn it back over to you, Colonel Coleman, pending any questions.
All right, thank you, Colonel Waldrop, for stepping through that. I think it's of note that there are over 100,000 different data points that have been collected throughout the environmental sampling study. And as we continue to go through that, that will be very important as we talk later about hazard documentation and how we conduct our health risk assessment. What we want to move to next is really kind of discuss the ongoing efforts that we have in the missile community to kind of make sure that we are providing a safe environment for maintainers and our missileers. So, Mr. Miller, over to you. Next slide.
So at the beginning of this, we started reviewing all of the maintenance technical orders, civil engineering manuals, looking for where we've had possible exposure in the past and where we could have exposure currently. We've identified all locations, standardized the way we warn our technicians, provide cautions in the books, and direct appropriate safety gear in all locations where we currently have PCBs or have had PCBs in the past. So we have standardized the warnings and cautions and handling procedures for anything that could have been at any point in time associated with PCBs. We're also walking through the final stages right now on standardizing the signage to make sure not only current PCB containing components are clearly labeled, but any location where we know we have had PCBs in the past is also labeled, and including those signs in our periodic maintenance inspections to make sure if one gets knocked off, torn off, that at some point we pick that up and it remains part of what we do. It's not a one-time effort. We're working through with our depot field teams, improvements in the math environmental environment, if you will, for the LCCs and LFs, looking at where we can take ducts apart during our depot level maintenance, cleaning ducts, providing, although no air samples tested bad, we have the ability to clean those ducts, and we're implementing those steps right now. We have deep cleaning contracts in place from an industrial hygiene perspective at all three of the missile wings. That is not addressing PCB cleaning. Those contracts are addressing industrial cleanliness of the the launch control center specifically. We also have a PCB cleaning contract with an outside agency that specializes in hazardous material cleanup. That contract is beginning in November. 4 LCCs per wing on the first task order. And as we progress, we can implement additional task orders, and we will implement additional task orders as we move forward. Launch facility testing, the first round has been completed. Sample size across all three of the operational missile wings, and we're pending the results being posted for that.
Thank you, Mr. Miller, for that update on our ongoing activities. And so we'll move on to the next slide and bringing all this full circle. And so in conducting all of the environmental sampling efforts really brings us to this stage. And the question that we often get is, how do we document any potential exposure, get that into our medical records? And so that's a concern for those that are serving, but also for those who have served. And so we're trying to address that in multiple ways. One, we're sharing with everyone. If you have any health concerns, please go see your primary care physician and get that documented in your medical record. That second area, for those that are serving, getting ready to retire, or separating, when you have your separation health and physical exam, please make sure that that information is shared during that exam so that it can be added and included into your medical record. We also published a polychlorinated biphenyl memo earlier this summer, and in there it references that the environmental sampling effort identified the continued presence of PCBs in the Minuteman missile alert facilities, despite a comprehensive removal effort. While unable to sample decommissioned sites for the Peacekeeper and Titan weapon systems, a review of technical data showed that PCB-containing components were likely used in those alert and control facilities given the construction timeframe. So we want you to share that, whether it's in your separation physical or if you're seeing your PCM in the civilian community and the VA. Please take that as evidence that that was an environment that you worked in. We've also shared that memo with the VA so that they have a copy of that as well.
And that memo's on our portal too.
Yes, sir. And so that memo is available on the Missile Community website, so you can download that. And so those are the most immediate ways to get some documentation taken care of. Going forward, in the Defense Occupational Environmental Health Readiness System, where we track exposures, environmental monitoring data, and health risk assessments, we are standardizing the approach across all the missile wings and conducting a health risk assessment at each missile wing. So the bioenvironmental engineers are doing that assessment, and they're doing interviews with the supervisors and loading individuals into that system. And that is on track, as we had previously discussed, to be complete by the end of the calendar year. And so all of that information, your individual information then connected to that DOOR system, will be visible in the individual longitudinal exposure record, known as EILER. That reflects the data indoors into your EILER. It's visible by the VA as well as your DoD providers at this time. And the information in there is somewhat location-based data for OCONUS. For the CONUS, we are working with the DoD EILR committee to connect data systems together so that you have the ability to not only see OCONUS or deployed locations, but also to see in garrison locations where their hazards would be. And that's important because we are loading the information from our 3 missile wings into that system so that you'll have visibility for that. The other effort there is to expand access so that service members and veterans that have a common access card can access their own data, and that's on track for 2025. And that will grow to eventually for our veterans to being able to sign in without a CAT card using a login in future iterations. And so the ability to be able to connect and come full circle, taking all of those sampling effort, those hundreds of thousands of data points, to getting assessment to build a health risk exposure for each individual, where they work in their occupational shop. We were doing that through this system and then connecting that to EILR, so you've got a long-term vision of where potential exposures would be and documented in your health record. And so from there, that would cover for those that are serving currently in those environments. But we know that there are a lot of questions that come from those that are no longer serving in those environments or have served in locations that are no longer active. And so the next way that we get after that to look into it is through the epidemiology review. And so we'll transition the epidemiology piece, and I'll let Colonel Woodruff and USAF Sam and the doctors of epidemiology kind of speak through the study and the efforts that they've done. Next slide.
All right, thank you, Colonel Coleman. Again, this is Colonel Anthony Waldrop at USAF SAM. Today's update provides interim results of the Phase 1 Bravo of the epidemiologic study using a total of 4 data sources. These data sources are the DoD electronic medical records, which, by the way, is what the analysis for Phase 1 Alpha included. But Phase 1 Bravo also includes the Department of Veteran Affairs electronic medical records, tumor registry data from the Veteran Affairs Administration Central Cancer Registry, and tumor registry data from the Department of Affairs Cancer Registry. The study protocol calls for a phased analysis with additional data sources being added until incidence and mortality rates are complete as possible. The next phases incorporate additional data from the National Death Index in Phase 1 Charlie, and we hope to soon to be able to report that. And also the virtual pooled registry in Phase 2 Alpha, or Phase 2. The virtual pooled registry is managed by the North American Association for Central Cancer Registries, and it's funded by the National Cancer Institute, and is designed to efficiently connect researchers with multiple state and local registries. Since Phase 1 Alpha interim results were released, study methodology was further refined in accordance with guidance from external partners. One significant adjustment required individuals to serve for a minimum of 1 year in the career field. Standard occupational cancer studies generally require a minimum of 1 year duration of employment to be included in the analysis. And this excluded 734 individuals from the analysis, which approximately 19,000 were from the missile community cohort, and approximately 186,732 in the non-missile community cohort, as we were unable to confirm that they contributed 1 full year of employment in the Department of the Air Force. Next slide, please. Before we move on to the results of the interim results, a quick comment on interpreting the results. The internal comparison of the missile community and the active duty Department of the Air Force non-missile community is directly comparable using a statistic known as the incident rate ratio. The incident rate ratio, also known as the IRR, is derived from dividing the incidence rate of a particular cancer in the missile community cohort by the incidence rate of the same cancer type in the non-missile community cohort. However, because we cannot directly calculate the incident rate for the United States general population, the appropriate statistic is the standardized incident ratio, also known as the SIR. The standardized incident ratio is the number of a particular cancer type in the missile community derived or divided by the expected number of cases of the same cancer type. The expected number of cases are derived from the National Cancer Institute SEER data, which provides age, race, sex-specific cancer rates for each demographic slice for each year. The next step is calculating the amount of person time contributed by each demographic slice for each year. Person time is a measurement that estimates the total amount of time that participants are at risk for developing a disease or dying, in this case, either cancer or dying. Once you have the annual age, race, and sex-specific cancer rate and the amount of annual person time contributed by that rate, that age, race, and sex-specific demographic slice, then we would multiply them together to get the expected count for that demographic for that year. We repeat those calculations for each demographic slice of the missile community for each year and add all the slices together to get a total expected number of cases in the missile community. Since there are 90 possible demographic combination slices per year, it takes special statistical software to make these calculations. And sir, we can continue on the next slide or take questions.
Hey, Shiner, we're going to continue the briefing and we'll take questions at the end.
Okay, very good. So the basics epi statistics continued. We'll discuss a little bit about how do you interpret using the IR or the SIR. So once the calculations for the incident rate ratio and the standardized incident ratio are completed, we can interpret similarly. If the incidence rate ratio or the standardized incident ratio is less than 1, then it means the incident rate is lower in the missile community. If the incidence rate ratio or the standardized incident ratio is equal to 1, then it means that the incident rate is the same in the comparison groups. And if the incidence rate ratio or the standardized incident ratio is greater than 1, it means that the incidence rate is higher in the missile community. Additionally, the calculation of confidence intervals and the p-value statistics allow for the determination of statistical significance, which means a result that is unlikely to be explained by chance or random factors. If both the lower and upper confidence intervals are less than 1 and the p-value statistic is less than 0.5, the incident rate is lower in the missile community and the result is statistically significant. If both the lower and upper confidence intervals are greater than 1 and the p-value is less than 0.5, then the incidence rate is higher in the missile community and the result is statistically significant. And finally, if the 95% confidence intervals cross 1 or the p-value statistic is greater than 0.5, the result is considered not statistically significant. And in other words, the incidence rates are similar between the two groups being compared. Next slide. So thus we'll look at some of the results, and in this case, as we move into phase 1 Bravo results, we want to emphasize again that these are interim results, and they are not final until we have a lot more data to receive from the state cancer registries to incorporate into the phase 2 analysis. Table 3 here represents the number of cancer cases by cancer type for the missile and non-missile communities from January 1st, 1976 to December 31st, 2020, and that resulted 55,224 cancer cases. You'll note that prostate cancer was the most common type among both the missile community and the non-missile community. Lung and bronchus cancer was the second most frequently diagnosed in both groups, and colon and rectum cancers were also relatively common. An individual may have more than one cancer type, but not more than one case per type of cancer in this analysis. Next slide, please. The internal comparison, which is table 6, presents the incident rate ratios for aggregated and specific type of cancers comparing individuals in the missile career field to active duty service members in non-missile career fields, which is adjusted for age, sex, race, and rank. Cancer incidence rates occurs at different rates in different age, race, and sex groups, so adjusting allows for an accurate comparison. The results suggest that there is no statistically significant difference in the incidence of most types of cancers between the two groups, as indicated by IRR rates that are close to 1.00 and p-values being above 0.05. Overall, the missile community has had a significantly lower IRR rate for all cancer types in both sexes compared to non-missile community. And specifically, the missile community shows statistically lower rates of urinary bladder cancer, lung and bronchus cancer, and prostate cancer. Among the male missile community population, overall cancer risk was significantly lower compared to the male non-missile cancer population. However, the overall relative difference in cancer incidence among the missile community and non-missile community females were not statistically significant. There were no statistically significant differences in cancer rates for most other cancer types when comparing missile community versus non-missile community populations, which is represented in this internal comparison group. Next slide, please. The external comparison, Table 5, presents the standardized incidence ratios for different types of cancers in the missile community compared to the U.S. civilian cases. Almost all the standardized incidence ratios were less than 1.0, suggesting that the missile community had lower relative risk for developing these types of cancers than the general U.S. population. Breast cancer had a standardized incidence ratio of 1.0, indicating that there was no difference in incidence rates. Moreover, ovarian cancer had a standardized incidence ratio of 1.32, which is above 1, but was not statistically significant given the fact that the p-value was 0.66, and likely because it relied on low case counts. There was only 5 observed cases, and we had 4 expected cases. So non-Hodgkin's lymphoma was not found to be elevated in the missile community compared to the U.S. general population, with the SIR rate of 0.57 and with a statistically significant p-value of p less than 0.01. The incidence of urinary cancer, bladder cancer among missile community was 71% lower than the general U.S. population and was the lowest standardized incident ratio reported. For Hodgkin's lymphoma, the standardized incident ratio was not statistically different and was close to 1.0. Next slide, please. If you're paying really close attention, you might have noticed that the dates and therefore the counts were different in tables 3 and tables 5. The external comparison only considered 2001 to 2020 in this phase of the MCCS in order to allow more accurate comparison with the SEER data. SEER data forms the basis for the civilian care comparison group. While SEER data is available back to the 1970s, our data sources for the missile community are most complete starting in 2001. The first year that all the databases including phase 1 Bravo analysis were available in 2001. And so between 2001 and 2020, our capture of cases is as complete as it can be for phase 1 Bravo data sources. And this includes 85% of cancers found in phase 1 Bravo. In phase 1 Bravo, only the Veterans Administration Cancer Registry actually goes back to 1976. Analyzing the whole study time frame from 1976 to 2020 would have added a lot of person time, which is a factor in the analysis, but only added a disproportionately small number of cancer cases. The standardized incident ratios, which were mostly already lower than 1, would have been even lower due to this known data gap. Phase 2 analysis plans to include cancers from the entire study period for both the internal and the external comparisons, since we still have additional data sources to cover this entire period of time. Next slide. Thus, the Missile Community Cancer Team has sought collaboration and support from dozens of individuals and organizations in planning, design, collection, and analysis of data and reporting. For phase 1 Bravo, our external partners included experts from Wright State University and the National Institute for Occupational Safety and Health. I'll also point out our other partners included the Air Force Global Strike Command historians, the Air Force Surgeon General Tumor Registrar, Armed Forces Health Surveillance Division, the Association of Air Force Missileers, Defense Centers for Public Health, Aberdeen, the Defense Health Agency, Privacy and Civil Liberties Office, the Department of Defense Joint Pathology Center's Tumor Registry, Department of Veterans Affairs, Hematology and Oncology Consultant of the Uniformed Services University, Department of Defense Murtha Cancer Center, the National Cancer Institute, the National Institute of Occupational Safety and Health, National Institutes of Health, the Secretary of the Air Force's Office, Montana Department of Public Health and Human Services State Epidemiologist, North Dakota Department of Health and Human Services State Epidemiologist, the Surveillance Epidemiology and End Results Program, Torchlight Initiative, United States Congress, the Virtual Pooled Registry, the Missile Wing Leadership and Missile Community members in those locations, and the Wyoming Department of Health epidemiologists. Phase 1 Bravo included considerably more data, capturing nearly 11 times more cancer cases compared to Phase 1 Alpha. Phase 1 Alpha captured the Department of Defense's medical data only. Phase 1 Bravo added the Veterans Administration medical data and tumor registry data from both the Department of Defense and the Veterans Administration. The study team anticipates finding 2 to 3 times more cancers in Phase 2 using the virtual pooled registry, and no definitive conclusions should be drawn until Phase 2 is complete and all data sources have been incorporated. And I'll turn it back to you, Colonel Coleman, and take any questions.
Thanks, John. I just want to kind of emphasize a few things that, and you guys can correct me 100%, but of Phase 1 Alpha, what Phase 1 Bravo, and then Phase 2, to your point, the release of the preliminary information is just in an attempt to be transparent, not definitive in the discovery journey yet. And we're about roughly 50% of the data that's out there. We still have another 50% of the data to go through. So the data is instructive, but I just want to caution folks that don't draw definitive conclusions from the data yet until the report is done and all the data analysis is done. The other thing I'd like to highlight, Shiner, and again, and feel free to expand upon it, is part of this process from day one has been to include external peer review processes, and you highlighted some of that in your first opening statement on this slide. But part of it is just making sure that the Department of Defense, Department of the Air Force, as a part of this analysis in this cancer study, that we have external eyes and expertise to make sure that we aren't missing anything. If you or Greg could kind of expand upon that.
Yes, sir. You're absolutely right. I appreciate it, General. Especially the Wright State University and the National Institute of Occupational Health and Safety has given us huge support and made recommendations, tangible recommendations to improve the study. Again, I'll point out the recognition that from the NIOSH that standard cancer studies typically exclude folks if they haven't been employed for more than a year. And so that's standard expectation in this type of study. And so we implemented that into the Phase 1 Bravo analysis. And so we tried to explain why that was the case. And so we are relying on outside partners to help us to improve and make sure that we do the best possible case we can for our missile leaders.
Thanks. And if you don't mind, I know we've done this in previous town hall forums, but if you could briefly just kind of run through the expertise and background of your teammates at your organization that have been part of this study.
Yes, sir. We have for the sampling and eventually the hazard risk analysis that will eventually be completed, because on the hazard and sampling side of the house, our bioenvironmental engineering, occupational health and safety teammates have done the analysis, done the collection of the sampling, and then they will use that to eventually develop a health risk analysis that we expect will inform. I'll also add too, NIOSH has been very instrumental with regard to the health risk assessment component of this as well. So, our teammates on the bioenvironmental engineering side included industrial hygiene as well as bioenvironmental engineers. For our epidemiology consult service, we have both preventive medicine physicians as well as epidemiologists that have been actively involved with the design and collection of data and the analysis of the data. And so, our team's here at your disposal as well as the community, sir.
So Colonel Waldrop, I think, correct me to 100%, but your team's made up of not only just the active duty uniform members that also have doctorate degrees in epidemiology, but of civilians as well. So these are experts in their field. They're scientists that are doing this level of analysis and work. Is that accurate?
Yes, sir, that is correct.
We go to the next slide. So thank you for walking us through all that. I know there's a lot of technical data there, but as we post this slide deck at onto our Missile Community website, along with the epidemiology report from Phase 1 Bravo, we want you to be able to use the documents to reference one another so that you can look at the data yourself. Again, in our effort to be transparent, we'll have that out on the website for you to look at. As we continue to go forward, we will, and on the environmental sampling piece, there would be a comprehensive health risk assessment done. And that will, as we talked through before, be available to to link with doors and assess the health risk exposure that our missileers and missile community work in. We'll close out the launch facility PCB sampling results, and then we'll continue on to the next portion of the epidemiology review, the Phase 1 Charlie data set, and then we will begin analyzing Phase 2. We have future engagements set up with the VA's Military Exposure Council. We'll be briefing them next month, and then again in December, another working group that they have there. And then finally, we have our site available. There's a QR code there for you to ask questions. We are going to continue to run forensics to make sure that the answers that we are providing are getting back to you. And close that loop so that we don't have any gaps in our communications to you, whether through this forum, the website, or directly as you ask us questions. And so we're committed to closing that loop with you as well. So, sir, at this point, I'll turn it back over to you.
Okay, thanks, Greg. So either for you or Shiner, can either one of you talk to, there's been some feedback and concern that there's been significant water contamination in the missile alert facilities. Have we discovered any in our environmental testing so far? Have we found anything with the water in the MAFs or the LCCs, either for Greg or Shiner?
Colonel Waldrop, you want to start first?
Yes, sir. And I'm going to defer to my subject matter expert here, Lieutenant Colonel Scott Boyd. Scott.
So out of the 3 rounds of this study, we've collected about 810 drinking water samples, which analyzed over 43,000 total chemicals. All results were non-detect and or below their corresponding federal health limit. So we have detected no issues where we think there's an issue with the drinking water. Over.
Okay, thank you. That's what I thought, but I wanted to make sure I wasn't missing anything. We've also gotten feedback that from our last town hall meeting, that questions that were submitted to our portal have not been answered. We are going to take that for action because they've all been received and replied to. So we don't know if there's a system on the far end or up in DC, but we'll take that for action because all the questions that were submitted after the last town hall have been answered and responded to. So obviously there's a technical issue somewhere in the system that we will pull the thread on. And then the last thing I'll say before, John, if you can start teeing up the questions, the last thing I'll say is kind of end up where I started in the beginning is this effort is really focused on today, making sure we understand today and we can capture the historical data. The way I would see it, and we don't have this completely framed and codified yet, when this report is done and we understand the environment that our missile operators have served in the last few decades, that will provide the study, our assessment of the exposure, and we'll put that out on our public-facing website, and we'll work with the VA to make sure that any exposure is documented, not only for our current members that are serving, but for those that have left the missile career field, separated or retired, so that we can provide that information if they need documentation for service and benefits. So John, over to you to start processing the questions.
Copy, sir. Thank you. Just some station keeping announcements. We have gotten quite a few questions via chat, more than I think we can reasonably answer in the time remaining. So just a reminder, please keep submitting those questions. You can DM them to me in the chat. I'm Lieutenant Colonel John Severns. And any questions we do not get to today, our staff will work to answer and get posted on the Missile Community Cancer Site website. In addition, because it is a common question, we will be posting these slides on the website after today's town hall. They should be up by tomorrow morning. Sir, with that, we'll go to some of the more common questions. One that's been asked several times, I'm going to try to kludge it together. There have been several known spills of various chemicals, either PCBs or various other hazardous materials at the missile sites over the years that have been documented by AFGSC and other agencies. Is the study doing anything to look at those specific spills and what personnel may have been exposed to them? Over.
So Colonel Waldrop, I'll give this a shot or address it, and then I'll leave it to you to add any specific details. But as we've got to walk through the study, what we can sample from what we know today of the 3 missile wings, is we can conduct sampling at those active sites. We can't necessarily sample anything from the past. So in order to kind of assess what that environment was like in the past, we're using the retrospective epidemiology review to get that assessment. And that is those 4 distinct data sets that walk through to see if there is any level of disease that we pick up during the epidemiology review. We have heard this quite frequently about spills or other environments that are no longer active. And the epidemiology review is our most complete way of assessing that time frame, since we can't actively sample that. But
so Greg, I think the more efficient way of addressing that is what Matt briefed earlier. Is we have done and we understand, based on the TCTOs of the previous systems, what chemicals or contaminants might have been present in the LCCs. And to Greg's point earlier, we have some of that already on the portal. That's probably a more efficient way of understanding exposure. And so if there's prior service members, I would recommend you go to our website portal first and look at that VA letter that we have posted, and see if your period of service is commensurate with what we know to be true based on the industrial standards at the time. And that should be sufficient for exposure. I'm not sure we can go back in history and say AFGSC has a spill report and then tie a person's missile duty to that time period. I think that's probably not necessarily a detail that's in the archives, but I'm not sure it's required either, because we have the data on what was in the system in previous decades and in previous weapon systems. That should be sufficient to acknowledge exposure for prior service members. Shiner, do you have anything to add to that?
General and Colonel Holman, no, that encapsulates exactly. I don't have anything else to add to that.
All right, thank you, sir. Next question, and this was one that several people asked as well, about the methodology of the study. Can you provide a bit of information about who the peer review is, and what, how they are basically checking our work? And also for USAF-SAM in particular, can you describe just what the kind of expertise or experience there within that command is when it comes to epidemiological studies in general? Over.
Okay, yes, we can do that. And in fact, I'm going to defer to Lieutenant Colonel Keith Beam. He's on the study team, and he can describe that for you.
Good afternoon. So let me just first introduce myself, Keith Beam. I'm a PrevMed physician, and we have a couple of PrevMed physicians on the team. We have a public health officer. We have a number of epidemiologists. We have folks who have a doctorate in public health. So that kind of is the makeup of our team. In terms of the external partnerships that we've sought, I think Colonel Walter read off a quite lengthy list of individuals that have been involved throughout the planning process of study design. But during each phase, starting with phase 1 Bravo, we've really engaged even more with specific external partners on each phase. So so for phase 1 Bravo, we partnered with experts from the NIOSH, National Institute of Occupational Health and Safety, and with experts from Wright State University. So those are the individuals that with whom we've shared our results, and we've shared with them the memorandum that has been made available to Air Force Global Strike Command, and they have helped us greatly with with our study methodology and with interpretation of the results. Also, we have a doctor of public health over at the DCPH Aberdeen, who has been just very instrumental as well in helping us to really understand the military population as well. He's one of the senior epidemiologists over there.
Sir, yeah, go ahead. I was just going to turn it back to you.
All right, thank you. Next question, and this one was submitted
John,
by.
John,
yes, sir, go ahead.
Let me expand upon that a little bit. So, I sense in the community writ large that there is some skepticism based on the results of the 2001 and 2005 report. I share, and I've been very vocal about my unsatisfaction with those two reports. But this study, this effort, and this energy is significantly more focused and engaged than those two times. And some of it's because you have a MAGCOM commander pushing on this, but there is no organization in the Department of the Air Force that is better postured or prepared or has the professional competencies to do this than USAF-SAM. There isn't. And I would ask the collective group of operators out on the net and in your close groups to trust that we have this at hand and have your interest in hand. To Greg's point, the department's never done a study to this level, scope, and scale. You have our commitment that we're going to do it right. You have our commitment that we're going to make sure we have appropriate peer level review from outside agencies to make sure we didn't miss anything. And our intent is to document and make sure that we have the proper data that is respected both by the Veterans Affairs as well as the Department of Defense and Department of the Air Force. So no one's going to question, in my opinion, this report when it's done, similar to what was questioned in previous studies. So I acknowledge your skepticism, but I'd ask for both patience and trust that we're going to get it done right this time.
Thank you, sir. Another question that came up several times: what is the service doing to mitigate toxins and or to create a safe environment for service members who are currently serving in facilities where toxins or hazards were identified in the environmental survey? Over.
So thank you for the question. This is Colonel Coleman. As I walked through and was describing the occupational shops that are being designed for the entire missile community, within those shops, there's a level of periodic sampling that must be done, whether that's on the air sampling, swipe samples that'll be conducted, as well as water sampling and others. And so that will be periodically done to ensure that there's a safe environment. And again, all that information will be documented every time that those events occur into that DOORS system, so that it will reflect in your medical record. And anytime that we're doing, I think we're also partnering with A-Force, and anytime inspections are done within those facilities and the weapon systems, another sampling effort will take place to ensure that we're continuing to provide a safe environment. So in short, really, the sampling efforts that we're doing now will become standard work as we go forward for those communities.
Yeah, and so when we discover something that's outside the standard, we close the facility to access or mitigate to the point where we're satisfied of the safety and well-being of our airmen. Is Stacy Joe on the net?
Sir, it would be difficult for me to find and bring her up at the moment. If you give me a minute, I can. Over.
Okay. Matt, do you have anything to add to that?
Yeah, the only thing I would add to that, sir, is as we move forward, you know, when we implement something into the weapon system, we use the least hazardous material possible, and PCBs specifically, you know, have been outlawed. We are installing nothing in the weapon system currently that contains PCBs, nor will we as we transition to the next iteration.
Yeah, so it was in the 70s when the government and the Environmental Protection Agency outlawed the use of PCBs in industrial areas. And that's when the process started. And I don't have the letter in front of me, but I believe it was the mid-90s, 1996, when the Department of the Air Force directed the mitigation steps within specific to our weapon systems. There are no reintroduction of those type of chemicals in the workplace now, and we're very cognizant of that. So our sampling, our cleaning, and our contract mitigations for specific to PCB is our current steps. And that's just specific to the PCB and the LCC, even though we're doing our other samplings more routine. To Greg's point earlier, the environmental health linkage with the missile operators is also going to be another safety check.
Yes, go ahead, Major General Hoosier.
Hey, Stacy Joe, do you have anything to add to that as the 20th Air Force Commander?
Was it about the cleaning plan, sir, that you're referring to?
No, just specific. The question was, how are we going to make sure our airmen are operating in an environment that's safe?
Yes, sir. You nailed it. So not only are we implementing the Launch Control Center deep cleaning specifically aimed at the PCBs, but then from now on, there's going to be continuing sampling that occurs, you know, until this system is replaced. So we'll be continuously monitoring the environments in which not just our missileers, but in which our maintainers and defenders, our chefs, our facility managers, in which they work to ensure they're all safe.
Thanks, Stacy Joe. And you won't find somebody that's more passionate and engaged on this topic than the person that's on the screen right now.
All right, sir. Next question is, again, for the medical professionals, and this is one that came up several times. Many folks have asked if there is a way for them to confirm that their specific case of cancer or medical issue is included in the study. And also, is there a way that they should be talking to their providers about the potential enhanced risks for developing cancer that they may have as a result of working in these facilities? Should they be asking for specific tests, or should they be using the memo that we produced, or any other method? Over.
This is Colonel Waldrop at USAF-SAM again. In general, I'd say the results of the large epidemiologic studies, such as this study, the MCCS, are generally applicable to the entire population, meaning the missile cancer community, regardless of the individual's participation in the actual study. And the design of the study is to really capture in a scientifically valid way, although some of the data may be de-identified, using the databases to the fullest extent. We intend to capture everyone that we can in the analysis of the study. Now, there will be, like, for instance, again, going back to the 19,000 individuals that were excluded from the missile community cohort because we could not validate that they had 1 year of service or employment within within that timeframe, it was advised that we should exclude those folks to improve the potential for finding those potentially small signals in cancer rates. So, so in that regard, we think that the study as of such is the best possibly designed at this time to detect those increased rate or potential increased rates of cancers. And if you don't mind, can I ask what was the second part of that question?
Yes, sir. This question was, how should individuals who are concerned talk with their providers about those concerns? And is there any specific testing that they can or should ask for? Over.
Oh yeah. So at this time, if somebody well, really anybody, but if a missile community member has concerns, I would encourage them to seek out counseling with their individual PCM. Now, the letter that's the SON PCB letter that explains the fact that this potential hazard was in the work environment, certainly that can be provided to the healthcare provider. The healthcare provider can document that in the medical record, as well as even upload a copy of that letter into their medical record for additional purposes. But if somebody has symptoms and concerns, that might be related to non-Hodgkin's lymphoma or some other type of cancer, then certainly seeking out an evaluation by their primary care physician is appropriate. And at this point, what has been communicated to the medics in the field is just be good doctors and healthcare providers. And so if that means doing an exam that's consistent with the symptomology, then they should do so. And such, if it's a situation that maybe this is a decision point between the healthcare provider and the individual person. We advise at this point to, with regard to developing standardized medical exams or required, sampling of human tissue or this type of stuff, to be patient until the completion of phase 2, until we really understand what phase 2 is actually going to inform us. And we are trying to do that analysis as quickly as we can. It's just the timelines with regard to obtaining the data, and then there's a bunch of steps in terms of dealing with the data so that we can get it in an appropriate format to do the analysis. Yes.
I want to add two things if I could. One that you mentioned very briefly, which was the information that we find as we go through the study itself. We are sharing with the providers, not only within Global Strike, but across the Air Force, so they understand, they have knowledge of what's happening in the study. And so when you as patients go to see your provider, they are also up to speed with what's going on. The other thing I would advise anyone that may have concerns to do is during your PHA, or your physical health assessment, towards the end, there's a text box where you can free text any information. If you free text in there that you have concerns about your environment or specific things, that automatically gets added to your record when you do that assessment. So just two things. We continue to want you to engage with your providers, do a face-to-face PHA appointment if you desire to do so, but manage that portion in just another way for you to document that. You have a record of it, and it automatically feeds into your medical record. So,
thanks.
All right, and a follow-up to that, hopefully able to address quickly. For separated members who no longer have a military PCM, what should they be saying to, say, Veterans Affairs members about their concerns, and how should they use the memorandum? Over.
So again, this is Colonel Coleman, and again, thank you for the question. We designed that PCB memo for you to download and take to your provider to be able to explain them the environment that you were working in, and that this was a known hazard in that environment. So again, take that documentation, have that added to your record as you're having those individual discussions with your primary care physician.
All right, thank you, sir. Next question is a methodology question, and it's asking about the different AFSCs and how they were binned as part of this study. One of the slides showed the larger group of 65,000 or so missile-related career fields, and then the smaller group of actual missileers. Is there a reason the study is binning them in that method, and is there any way of looking at particular exposures that certain career fields may have had? Over.
Thank you. This is Dr. Beam again. That's an excellent question. So when we looked at the whole missile community as a whole, we wanted to capture or cast a very wide net and capture as many personnel who might have been exposed to any of the locations associated with the missile community. So we have a list of 100 or so AFSCs that we have validated through Global Strike Command, 20th Air Force, through the historians. You read through hundreds of pages of position descriptions and other documents that helped us to refine this list. And then based on those on that list of AFSCs, we identified which of the 4 exposure locations that they would have come into contact with, whether isolated to the MAF or the LCC or launch facility topside or launch facility underground, and so that's how we've broken down those or binned. I think the word you used was that's how we binned those AFSCs for now. Just the locations that they would have come into contact with, and during this phase of the analysis, we went through those various exposure groups. We performed those individual analyses on each exposure category, comparing the incidence of each cancer in each missile community exposure category to both their non-exposed counterparts and to the general U.S. population. During this phase, these analyses did not show any statistically significant increase in cancer in any of the missile community exposure groups. However, some of those analyses were underpowered, just meaning that more data points are still needed. So additional data from phase 2 will help to solidify our understanding of cancer risk in those exposure groups and in the missile community overall. Hope that answers the question.
Thank you, sir. Next question relates to the facilities. They heard today that PCBs in the LCCs are being mitigated and cleaned. Those are 2 separate things. Are PCBs being mitigated in the sense that their source is being removed from the equipment, or is the simple spillage being wiped up and cleaned up? Over.
So this, Mr. Miller from A4, in the instances where we have PCBs present, the first step is to contain and clean. And then any component that is exposing, PCBs to the environment would be removed and replaced.
Thank you, sir. Next question is, again, going back to some spillages that are known to have occurred in the past. There was a study that found what are said to be abnormally high levels of radon in the facilities, and that these results may have been discounted because they were unrealistically high. Is anyone familiar with those studies, what their outcome was, and if there are any new results regarding radon testing in the facilities as part of the current study? Over.
I'm sorry, go ahead, sir.
No, this is in your area, so go ahead.
Okay, so as far as the radon sampling during these 3 rounds, we did sample all 45 maps for over 270 days. We also sampled 4 facilities at Vandenberg with 5 facilities at Hill Air Force Base. We did sample quite a long period of time to get a very sufficient database as far as what radon exposures would go. And the results of these have indicated that they are well below the annual exposure limit as well as the facility mitigation threshold in accordance with Chapter 9 or Chapter 7 of AFMAN 48-148. Over.
Yeah, so our current testing under these protocols have not revealed any increased radon at any of our facilities. If somebody out there has information on a report somewhere, which we don't believe our historical records will capture that. But if you have a pointer that there's a report from a specific year group at a specific location, then we welcome that, but we're not tracking that here.
Thank you, sir. We have another question on methodology. This one is about, was there any attempt to examine the results within the missile career fields based on their location? That is, were results from, say, Malmstrom different from results at F.E. Warren or Minot or some of the historical sites? Over.
Hey, this is Dr. Beam again, program physician on the EPI consult service. So that is planned to be done at the completion of phase 2. Once we have a full data set that is as complete as we can make it, that includes the 4 databases that we have already analyzed for phase 1 Bravo, and then we will add all of the cancer registries from the participating states in the virtual pooled registry. That's 44 additional state and regional cancer registries that will be added during phase 2. So once we have that complete data set, then we can kind of slice and dice different ways. Over.
Yeah, but correct me if I'm wrong, we're not going to be able to go to closed and analyze any closed, evaluate or analyze any closed missile wings or facilities, because I'm pretty sure the cancer data is not going to be specific to a wing or a location. Is that correct?
We're working through the AFGSC data to see what level of granularity and fidelity that we have on the assignments, but it might be difficult for bases that have been long closed.
Okay, so TBD whether that level of data fidelity exists.
Yes, sir. And also with the rotation through the various bases, identifying a particular base versus if there are multiple bases that they were stationed at, makes that a little bit difficult. But we're going to work with our dedicated external partners for phase 2 to get the most scientifically rigorous way of working that out, so that we can answer this question as best we can with the data that we have.
All right, thank you, sir. Next question is, and this is more of a recommendation than a question. It's asking, would it be possible to publish an environmental hazard roadmap or repository listing all of the known environmental hazards, such as major PCBs, spills, leaks, contamination, underground storage, plumes, etc., that are known to have occurred at the launch facilities over their history? Over.
I don't know. I'm not sure we have that level of data, but we'll ask the question. The way I understand the question, John, is there kind of a historical record where there might have been a fuel spill or a previous PCP determination, or radon determination from either a current or a previous missile wing? I'm not sure that data exists, but we will pull the thread on it. Over.
Yes, sir. Thank you. And I think this is the final question that we will have time for today. And it, again, kind of goes back to remediation levels. Understanding that they are different for each of the hazards that were tested for, how are we deriving what the safe levels are? And what are those safe levels, if it can be described succinctly? Over.
During the reports, we used a health screening value based on the Occupational Safety and Health Administration permissible exposure limit for an 8-hour time-weighted average. We are now moving to the final report, which will incorporate health screening levels. What our plan on this is to find the most conservative yet scientifically supported standard from federal and state levels, and those will be the levels that we adopt in the final health risk assessment. Over.
So let me ask you a question. This is Colonel Coleman, to what you just stated. I know that we look at often the 8-hour time domain, but when we look at that as it's explained, that also accounts for a 40-hour work week over the lifetime of somebody's working, over a working lifetime. So as we've done the analysis, have we also not looked at, on average, the amount of hours that a maintainer or missileer would be in that environment and level set against those to balance the exposure risk?
Yes, sir, we have. We've adopted procedures from the American Conference of Government Industrial Hygienists as well as the Occupational Safety and Health Administration. One thing to take note that these limits that are published by these agencies do not dictate what is acutely safe and hazardous versus hazardous. These reports are based on exposure limits derived from national consensus standards and recognized federal standards. Although adjustment calculations are available to correlate an 8-hour exposure to extended work periods, OSHA only endorses this method under two specific standards, and those are both related to lead exposure. Whenever you're dealing with extended work periods, OSHA endorses two methods of evaluation. The first is to sample the worst continuous 8-hour work period of an entire work shift or of a work shift, and the other is to collect multiple samples over the entire work shift, which will include the entire work period. During the MCCS, we employed sampling the worst continuous 8-hour work period. We only found trace amounts of VOCs that were detected all below the health screening value. When comparing these detections to a respective 8-hour exposure limit, we observed these levels to be well below 30% of the preliminary health screening values and often many times lower. So under this standard of very minor levels, we've come to the conclusion that the conditions that we sampled during an 8-hour period are actually conducive for a 24-hour extended work period.
Thank you.
All right, that brings us to 75 minutes. As a reminder for anyone whose questions we did not get to, we will compile those as best we can and get them posted on the Missile Community Cancer website just as soon as we can get those answers or those questions answered. These slides will also be posted on the website as of tomorrow morning. General Bussier, over to you for any closing comments. Over.
Thanks, John. Stacy, Joe, do you have any comments you want to make to the group before we close?
No, sir, I don't. Thank you so much. Thanks to your team and the USAF SAM team. I really appreciate it.
Thanks, Stacy, Joe. To those that, again, I'll echo Stacy, Joe's thanks to USAF SAM and your continued efforts along the studies, as well as Greg Coleman's team in here and Matt's team in A4, everyone that's working together to get this done. There's a lot more work to do. We will continue to keep you informed. I would ask if you have a question or a concern to send it in. And if you don't get an answer, come up frequency. Okay, if you're not getting an answer, call. We're going to go back and pull the questions from the last town hall that were pushed in, and then we will take those, and obviously members that put them in did not get their responses, so we'll just post those questions and responses onto our portal from the last town hall that somehow got lost in the technology world. Again, thanks for everyone's interest. Thanks for your efforts to keep this on the front burner, and we'll keep you informed as the study continues. Thank you.
Sir, if we have a moment, Dan Holmes is on and has a question for us. I'm going to go ahead and unmute him. Go ahead, Dan. Dan, you should be able to ask your question now. All right, nothing heard from Dan.
I'm sorry.
Oh, go ahead, sir.
Okay,
Go ahead, Dan.
Jean Bussier, you know me, okay. Okay, I'm Dan Holmes. I was a missileer in Titan II weapons system. Am I on?
Have you loud and clear, Dan?
Okay. I was a missileer in the Titan II weapons system at Little Rock back in the 70s, and I retired as an Air Force lieutenant colonel after 20 years. and I'm the father of Mark Holmes, Major Mark Holmes, who died of non-Hodgkin's lymphoma in May of 2020. And I had a series of questions, but I'll just cut right to the chase. A friend of Danny Seebeck's, an Air Force major who's a lawyer stationed in Colorado Springs and is a member of the Torchlight Initiative, stepped up and came alongside Jenny, my daughter-in-law, to help her appeal her latest VA claim, which was denied back in March. And we were told that this appeal could take another year. It took already 15 months before they decided to deny that claim. Well, while helping her with this paperwork for her appeal, Aaron had an aha moment, and he remembered that while an intern to become an Air Force lawyer, he worked on what's called a line of duty determination, where if a service member's death is determined to be in the line of duty, that the deceased family members would be entitled to full benefits just as if the service member had died on active duty. He wondered why the line of duty determination was never done by Mark's active reserve squadron at Schriever, of which he was a member at the time of his death. So he initiated a line of duty determination and submitted it to the reserve squadron there at Schriever just a couple months ago. This was approved within days, probably less than a week, by medical, the group commander, and the wing commander there at Schriever. But then it was sent to the higher ups at Air Force Reserve headquarters at Warner Robins, where it was denied. So after pulling over 300 alerts, which is over 7,200 hours below ground in the LCCs in a 4-year period from 2007 to 2011 at Malmstrom, my son's death was determined to be not service related by the VA and not to be in the line of duty by the Air Force. Mark died in the service of his country, but in addition to fighting this gutless, soulless, heartless bureaucracy that is the VA for 3 years now it appears to our family that the Air Force, my Air Force, doesn't care either. Jean Bussière has commanded his leadership to treat their troops as if they were their own son or daughter. When is somebody sitting around that table there at Barksdale going to treat Mark Holmes as if he were your son and have the balls enough to pick up the phone and contact the VA and find out who's evaluating and processing Jenny's claim? Any one of you can call me after this town hall and I'll give you Mark's Social Security number, which is the same as Jenny's VA claim number. You can get my phone number from General Bussière. Like I said, I emailed him months ago and he immediately emailed me back, and then Tom called me on the phone the next day. So he has my phone number and my email address. When is somebody going to pick up the phone and call Warner Robins and find out why they denied Mark's line of duty determination? I mean, I'd make these phone calls myself if I thought it would do any good. I'm 74 years old. I don't care who I piss off anymore. But what do I have to do? I mean, I've already lost. What more do I have to lose that I haven't already lost? I just like somebody to do the right thing, to reach out to Jenny Holmes and her and Mark's 3 children there in Colorado Springs and start treating them like an Air Force family. That's all I have to say. I'm done. Thank you.
Hey, Dan, thanks for that. I wasn't tracking the letter. So I'll look into that and get back to you. I'm not sure if there's anybody from the VA that wants to respond that's on the net.
Sir, I am showing, I believe it's Dr. Hastings.
Dr. Hastings?
Unmute. I am off mute. Okay, it says I can't start my video, but are you able to hear me?
I do have you loud and clear, Dr. Hastings.
Sure. I was going to call Colonel Coleman after this. We've worked very closely, and I can talk to VBA and see what the determination was and how the determination was made, and I'd be happy to share that.
Thank you.
All right, sir. Appreciate the extended time there. As noted, we will post these slides online as well as additional questions and answers as we are able to get them answered. I appreciate everyone's time. I will stay in the chat for a few more minutes if anyone wants to direct message me additional questions. With that, we will call an end to today's town hall. Thank you very much. Over and out.